very much. Okay, so the co-facilitators, the senior facilitators, you are welcome to our module 3, and module 3 is on management of HIV and TB. So I admit those who are here, and then we give it some 2 minutes as wait for the others. Okay.
How are people? Evelyn, hello Evelyn, good to see you. How are you?
Malema has not yet joined. I don't know, he's stuck. Okay, so there are more. Let me admit everyone and then we can start.
Yeah, let's wait for a few more.
Yeah, but those who have already joined, you are welcome to today's session. As we wait for the other colleagues, if they are within your reach, send them a WhatsApp or a short message service, and then we can get started. Okay. Welcome our participants. We are just giving it some more few minutes as we wait for the others to join, and then we can start the serious business. So for those of you who have already joined, please register your presence in the chat room. You mention your name, your institution, and also you tell us your professional practice. We are just giving it some few minutes as we wait for the other colleagues to join us and we start. Okay, so we have reached the point where we have no more people waiting, and I see from the list of participants we are 16. I will keep checking for the people who will be coming in so that they also join us as soon as they come. I want to take this opportunity to welcome all of you to today's session, which is module 3. Module 3 is about management of HIV and TB co-infections. And my name is Ivan Mugisha Karimwa. I am presenting from Uganda. I work for Clark International University, and I am happy to be one of the facilitators for today's session. I am not facilitating alone. I have a very competent team, and I would like to give this chance to my colleague whom I'm presenting this week so that she can also introduce herself.
Good evening, everyone. My name is Matebo Hompana. I am a lecturer at National Health Training College, Lesotho. So today we are going to facilitate module 3 with Ivan. Before we start the session, we would like to welcome everyone, the participants as well as the facilitators, and we wish you the fruitful session. And we hope that by the end of this session, everyone would have at least learned something, just even if it is just one thing that you have learned. We believe that you'll be able to learn something from this session. So if I'm allowed, I can continue.
Please go ahead and continue. I am admitting as more come on, please. Let's start the session.
Yes. Okay. No, thank you very much. As I have said, we are going to facilitate management of HIV/TB co-infection, which is module 3. And I think it is important for us to highlight why is it important to talk about HIV, TB co-infection. You probably know, but I think it is more important just to bring us close together to highlight it. Over 70% of TB patients in the sub-Saharan Africa are also co-infected with HIV. And most of the morbidity and mortality in HIV is result from TB. HIV patients results from TB. So it is important for us to learn about this. And it has been found that HIV weakens the immune system such that it makes it difficult for the body to fight TB. So the latent TB that the patient may be having is easily reactivated to active TB disease. And even the new TB infection progresses much faster in patients with HIV. We also know that anti-TB treatment and ARVs, they do interact. HIV makes it difficult to diagnose TB and many other reasons, and therefore that is why it is very important for us to talk about management of HIV-TB co-infection among the many co-infections that we have. So I think we will continue. Ivan, please, the next slide. We will now continue and work with the slide. The first activity that we are going to have is the role play. And in this role play, we are going to, the objective is to discuss patient-centered approach to counseling patients about their TB regimen, medication regimen. Next slide, please. So our case here is about Jabari. Jabari is a 32-year-old shop attendant. He shares a house with his wife, 2 children, and his 64-year-old grandmother. Jabari presented to the outpatient clinic a 1-month history of cough, which has not responded to 2 courses of over-the-counter antibiotics. 2 days ago, he took an HIV test during a community HIV campaign, and he was found to be HIV positive. In addition to his cough, he has lost significant body weight. Next slide, please. So we are going to go into small groups, and in these small groups, we are going to have a role play. So this role play, we are going to divide our participants in such that we have one who will be acting as Jabari, and the other one will be the counselor. Then the third group of people will be the observers. I am not sure how many we are, but I think that we can divide ourselves into 2 or 3 groups if the number allows.
Yeah, so we have about 11 participants. I see there are more people coming. We will request that Winfred is able to make the distribution according to the available number. But what you have mentioned is the rightful one for each group, whether you are 4 or you are 6. You'll have one who will serve as Jabari, you'll have a counselor, then the other people will be the observers, and these observers have been given particular tasks. You need to look at the communication between the patient and the counselor. You also need to take note of the purpose of the communication taking place. Then you also need to look at the adherence, but also you need to talk about the toxicities, as well as the contingency planning and what follows later. And as it is a popular aspect for us, when you have the discussions, in the breakout sessions, you'll come back to us, and then we will have one representative for each group to report back to the main group. So this means that among the many people involved, you have somebody who will be taking a note and will be able to present on behalf of the other group. And if time allows, this activity has been given 10 minutes. If time allows, you can as well have another set of Jabari and the counselor. The more people involved in this role play, the better the outcomes. Thank you very much.
Thank you. I think it is clear now. We can break out to our small group sessions.
Yeah. Winnie, I am counting. Wow, welcome back from the breakout sessions. This was extremely very interesting. And at this point, without waiting any longer, we will be able to invite the different groups to give us the feedback of what took place in the breakout sessions. And then it will also be important that in case you have a point which can be added on what the group has already presented, you put it in the chat room, we shall be able to look at it and then we'll discuss more. So I start with group 1. Can you give us your feedback, please?
Andy, you can give feedback.
Thank you. In group 1, we sort of ran out of time. So what I observed was that the counselor was mainly asking some closed-ended questions. They asked a few open-ended questions to allow the patient to explain. And another observation was that there was really a lot of information for the patient. Maybe it would have been better if the patient had someone else, because there was about adherence, toxicity, and who else is at home. Yeah, I think those were my observations because I was a patient. So maybe another member of the group can contribute what they observed. Thank you.
Yes, is there anyone else who could add? I think we had 3 participants. So I don't know if the other person can add on, but basically that's what we had in the group, and I think we were short of time, and we're busy enjoying listening to the role play. Thank you. If there is no one, I think back to you, Ivan and Tim.
Thank you, Group 1. It was really nice to hear those deliberations that took place. You mentioned that you were not able to finish up everything. Our hope is that probably other groups will not experience the same, but if it is the same, we shall be able to again hear and we'll see. So the points are well noted. At this point, I also encourage Group 2 representatives to tell us about their discussions, and then we move ahead. Thank you. Group 2, please. Group 2.
Maybe if group 2 is not ready, we can find out from group 3.
Okay, group 3.
If we could find out from the counselor, from the patient, and from the observer, so that they can tell us how it went.
Group 3.
I don't know which group I was.
I think Selena was in group 3.
Yeah, so is it group 3?
Yes.
Okay, that is where we had asked who?
Evelyn.
Evelyn was the participant, but we asked Titi to be, yes, to be our reporter.
So I was saying we need to hear from the counselor how the session went. How did you feel as a counselor? And then the patient also tell us the experience as a patient.
Okay,
and the feedback from the observer, from Titi.
Oh, from the counseling side, it was not easy for me because I was under pressure of time, because we started very late. And now when one had to think fast to cover as much as possible around what is required. And yeah, but then I think I tried to as a counselor, I tried to ask open-ended questions.
Okay. Our patient.
The patient, again, I think Selena tried. The only time I felt uncomfortable was when she was saying they took your blood and your viral load is very, very high. I started getting worried, and I even said, what are they going to do about this high viral load? So she told me they will commence some treatments, I should eat well. That's when now I started to relax. Otherwise, I think the whole session went on well. She was communicating. She told me the purpose, how the drugs are going to act in my body, and then I should take the drugs every day. I might have some symptoms of side effects, which I can also go back to the hospital. So it was a nice session. Thank you.
Okay.
Thank you very much.
Very good feedback. And
Titi.
Anybody from group 3 to add on? If not, we go to group 2.
Good afternoon.
Yeah, good afternoon.
I think they did very well. What impressed me even more is how she welcomed the patient to the session. She recalled with the patient what they discussed during the previous session. And she also tried to explain the relationship between viral load and ART. She also talked about adherence and the implication of traditional and complementary medicine while taking ARVs. So generally, they did very well. And when the patient raised concern about TB, the counselor managed to solicit that in case that there is someone who they were contact with, contact tracing will be initiated so that appropriate services can be provided to the the family members. Thank you.
Thank you so much. Thank you. I continue hearing from the two groups that it was not a very easy task. Of course, you know, being a co-infection and what it involves and all that. So we continue to get the feedback. Group 2 members, I am part of it, so we should be ready at this time. We had asked somebody called Zerifa to represent us. So Zerifa, are you ready? If you are not ready, let me know, then we get feedback from some other person.
I'm not ready. My network, I think, is also kind of on off, so I may not contribute properly.
Okay, so in this case, I'll ask our counselor or Segun to be able to share with us the experience with the patient that you had. Thank you.
Yeah, but I can also just comment a bit while I am able to share.
Please, go ahead.
Yeah, I found it quite interesting, and I think the cancer also had was able to focus on the main issues that would affect the patient with the treatment and the new diagnosis. I think that's what I also felt, but I think the time ran out before our client could also ask more areas. So it seems like our client still had some questions or was not able to really grasp some of the information and needed more clarification. But all in all, it was good. And if we had time, I think we could have learned more.
Thank you for that report. And Segun, our counselor, do you want to add on a word or two? Thank you.
No, I think Saliva has said virtually everything. We had very little time on our hand. We started when we were about 2 minutes to the end of the breakout session, so we couldn't even really engage one another. The patient had questions to ask, and we were just at that point when the counselor was willing to explain things to the patient before we were caught up. So
Yeah.
we really did not have enough time on our hands. Thank you.
Okay, so it comes out that for the 3 sessions, both of them, the news of breaking the HIV, the TB co-infection, as well as the associated toxicities for the 2 drugs, especially knowing that TB will be treated for some time, but then HIV is a lifetime kind of treatment. It was not extremely very easy. And I want to agree with all your submissions that for such patients, because you do not want them to start on a long-term treatment and they drop it along the way, as a counselor, you have to do quite more and give as much explanation as possible, because if they drop the treatments, then the side effects will be much more and it will not be desirable for this kind of circumstance. Well, what is also true, as you were discussing, is that somehow, somewhere, these patients have a very big risk and they are a little bit unaware that it could actually happen like this. But also you remember that they are not only destined for TB as a co-infection of HIV, there are so many others. So it needs to be very clear to them that the effort for them to be initiated on treatment is also much desirable to improve on their neurological response and try to limit on the other possible co-infection that could take advantage of the weak immune response. So it is very clear that all the groups have been able to do enough discussions. We apologize for the short time. I don't want to take more time from you. I go back to the slides and we look at the next activity. So we have heard from the counselor, the patients. We have gotten some feedback from the observers, and at this point, I want us to leave this activity and we go to the possible answers. As you might have known, of course, there was a great need for us to have a clear communication, and this should be more aiming at helping the patient to be able to understand what they will go through and then be able to take up the necessary advice. And if accepted, then they should be able to start on the treatment right away. And then also the goals of the treatment have to be explained, knowing that these are two infections, and like one group mentioned, there is a very great interaction of the two drugs, the ones for TB and for HIV. So these people must understand this kind of interactions, which may also have some severe adverse events. Then because you have the long-term
Ivan, please
treatment,
play the slide.
are you not able to see this?
No,
You can't see the slide I am on?
yes, we can't see.
Oh, I'm very
Even
sorry.
Mariki wrote that she can't see.
I'm very sorry. I'm just trying to share. I think I lost the sharing rights. So this is the slide I'm talking about. And we mentioned that we need to make a proper communication to these patients and also make every effort possible to make them understand the purpose of the two treatments. Especially they need to know that there will be some associated side effects, but also there are so much benefits, especially if they are able to adhere to the treatment very well. And because you have the HIV treatment as a lifetime care, these patients must be able to keep on the treatment once they start on it. And then as expected, there will be some toxicities which create some a bit of discomfort, and sometimes they could actually make the patient more weaker, but important for them is to know that they can still be able to survive in that kind of a condition. Then we also need to advise our patients that they have to come up with an evaluation plan, and then in case they develop those rare conditions like a skin rash, or if they have some abdominal upsets, then they need to be able to get back to the hospital where they are assessed and they are taken good care of. And then as expected, these patients have to be followed up depending on the guidelines within the particular country. And importantly is that they will need to repeat these evaluations after so many times. We want to know whether the patient with TB has gotten TB cured if the lungs are sterile. And also it's very important that we are able to have them monitored for the different blood cell parameters, the CD4s. It's one way of us knowing that our patient is responding and all that. So this must be very clear to the patient, and the counselor should be able to have this achieved so that the patient can respond positively to this kind of condition. And of course, like you mentioned, both TB and HIV are treatable for some time. So when you have a patient who has been well counseled, then it puts this patient in a better position to be able to respond well, and then the outcome will be much better. Thank you very much. Now, this marks the end of our activity number 1, and I thank you for your active contribution to the same. We now have our activity number 2, and this is focused on the multidisciplinary discussion with an objective of looking at the interprofessional strategies to address the psychosocial concerns of TB at the different levels. So as we all know, TB is associated with a number of challenges, and they do not go unnoticed because they finally affect our psychological functioning. Now we want to look at those strategies that we can use to address the challenges at the individual, community, and also the institutional level. These are very important because they dictate on how our patients will be able to take up their, first of all, their diagnosis, but also how they will behave and respond when they are on treatment. And this, I will ask my colleague to be able to start from this. Thank you.
Thank you very much. We are now going to the second activity. But before we go to the second activity, I would like to just talk about the effects of stigma and discrimination on tuberculosis, just so that on tuberculosis, just so that we are aware why we need to focus on it. Because sometimes when we are not aware of how it affects us, we may not focus on it that much. Stigma harms the patient in that it hinders the health-seeking behavior of the patient. It prevents the patient from actually seeking for health services. It affects adherence to treatment, which in turn may lead to poor prognosis and sometimes also drug resistance. In addition, Stigma and discrimination erodes the healthcare worker commitment to high quality care by affecting contact tracing. Sometimes because of the stigma and discrimination, it becomes difficult even to keep the commitment to do contact tracing. Sometimes people who are supposed to be traced, they do not allow their family members to point them that they have been together with them for fear of stigma. And also outbreak investigations become difficult and the initiation of treatment becomes difficult. Therefore, it is important for us as healthcare workers to also look at ourselves and the community and the patients as the sources of stigma. So in this activity, we are going to answer the 3 questions. And the first one is, how can the patient, community, and institutions be sources of TB stigma? That is the first question. Then the second question is, how have you seen TB stigma manifest? The third question is, within the scope of your practice, how might you address this type of stigma with a patient like Jabbar? So we can go to our breakout rooms where we are going to discuss these questions.
Winfred, kindly allocate us the different room.
Hello, Winifred. Can you put me in another group, please? Just want to.
I'm making the
Thank you.
changes.
Yeah, I just want to check out all the groups.
It looks like we are back in the main group. Roger,
Hello.
it looks like we are back in the main group. I
No,
expect
we're in room 1. You haven't gone there.
I
You
was
haven't.
I was sent to group 3 and then back to group 1, back to main group.
No, you are at room 1 right now.
Okay, fine. If I'm in group 1, it's fine. I think we need to have somebody who will be recording for us. Can we have a volunteer to record for us as we discuss?
Please kindly join. There is a 3 button where you are supposed to like join the breakout room, because right now you are in the main room.
Have I joined now? It says I'm not joined.
Yes, it still shows here that you are not joined.
Welcome back. And it's very important that we hold the different groups accountable by telling us what they had in their discussions, and then we should be able to listen from each other and learn from one another indeed. So at this point, I want to start with the group 3, and I request that the representative of the group should be able to come out and tell us the different discussions that they had in group 3. Titi, please, you are the representative for that group.
Thank you. Within group 3, we discuss about stigma. We have got 3 different levels of stigma, starting with individual, institutions, and communities. So we identify that isolation, which is always a result in psychosocial stress, is the most common or prominent reason of stigma, and this is usually caused by lack of knowledge by the people. And from this lack of knowledge covers broad aspect. Firstly, if our client doesn't have got adequate knowledge, they tend to believe the myths and misconceptions that they hear in the community. So it's very, very important to take care or consider the knowledge of our clients when servicing them. Then the other thing that we also addressed was isolation, especially for the patients who are diagnosed with TB, and medically they are expected to be isolated. So the question was, what is policy saying about that? Are we not seeing that as itself being cause of the stigma to our clients? So it's one of the things that we ended up maybe without reaching the real conclusion. But the Public Health Act, I think in most of African countries, even in the US, it recommends that someone who is TB positive, smear positive, need to be isolated at least for the first two weeks or so. So I think that when educating clients, is very, very important to touch about on this policy, that it is recommended by the health or public health policy that if someone is smear positive, they need to be isolated from other ones. And to make sure that the clients, they understand the reason of isolating them is not to stigmatize them or discriminate them, but is for the benefits of the family members, the community member, and the health system at large. Thank you.
Oh, thank you so much for the comprehensive feedback. And I want to give chance to group 2. And in case you feel that some aspects have already been mentioned by group 3, please, you can read them out. It does no harm. Please go ahead and give us your feedback, group 2.
So I'm Sezo representing group 2. What we have discussed in terms of sources of stigma, starting with the patients themselves, we mentioned the issue of they being ashamed of having the diagnosis to a point where they want to withdraw from others and not associate with other people in their surroundings. And then also looking at the institutions, similar to what group 3 has already presented on, there's designation of TB rooms or units in hospitals somehow bring that stigma. And then we mentioned in terms of the community at large, you see that there are instances where people around you don't want to be near you because they fear getting the disease. There's also that myth of social background playing a role in TB, such that people believe that people who are, because you have TB, they tend to associated with low income status. So they would somehow look down upon the patient. And then we also had these issues of isolation still playing a role in communities being a source of stigma. And then in terms of other institutions apart from our healthcare, we mentioned that some people end up not being able to work. They're not allowed to carry on with the work duties at their workspace because they feel they might be infectious to others. Somehow, still in our health facilities, when they come for regular treatment follow-up. They tend to be isolated, asked to put on masks, asked to avoid handshaking. So that's on its own. If another patient, a non-TB patient, is on the other side, they can pick up, or there might be something going on, and they might associate that with TB and bring out that stigma. And then in terms of addressing, our main priority was on educating the patients themselves on the disease, the family, which are the primary caregivers, so that you bring down that fear that they have, and also the community at large on how they can be able to still associate with TB patients in the community. And at the same time, addressing any myths that are associated with TB as a way of reorientating the community. Some we agreed that isolation, we cannot for now address it because it's somehow expected, as mentioned by Group 3, that's as public health for policy. So you still have to somehow go along with what's already being done. So thank you.
Thank you so much, Titi. And I cannot emphasize anything more than that. I am very happy that you have been able to give us this information, and it should be able to reflect in our practice and also support these patients as required. Finally, Group 1 is given a chance to give us their feedback in regards to their discussion in the breakout session.
Yes, so for Group 1, as sources of stigma at the individual level, we discussed how there's often an automatic association of one having TB as also being co-infected with HIV and AIDS. So that could be a source of stigma at the individual level, as when a patient is TB infected, people automatically assume that they're also HIV positive, which can lead to a negative perception of that individual. And then at community level, we talked about how TB patients will often be feared and isolated, as the community might feel that they're contagious and will spread the TB infection to other members of the community. And then at institutional level, we also talked about the segregation of TB services from other healthcare services in clinics and hospitals. And one of our team members mentioned having that hospitals often have like a coughers corner where people that have a chronic cough will often be asked to go to cough to prevent this, to minimize the spread of infection. And then we also had the exclusion of TB patients from working certain jobs. And the last one was the long duration of TB treatment, which is usually a minimum of 6 months. So we said that it can be a source of stigma, as one who's on TB treatment, people often be asking what pills the patient is taking all the time. And then stigma, how it manifests. I think most of the points we had were mentioned. We also had that people will often physically distance themselves from a person that has a chronic cough and wouldn't want to touch or use the same utensils that the patient might have used. And then as the TB infected patient, he or she might feel shameful or guilty for having TB and also in turn isolate themselves. And then to address the stigma, our main key was to educate the patient and the community at large about the transmission of TB, its risk factors, how it presents, and to educate them about the management and treatment, and to tell them that it's curable, as often stigma is a result of misconceptions about the disease. That's all from Group 1.
Thank you, all the representatives. This is very important, and I am happy that they have had a comprehensive discussion. And I for sure believe and agree that this reflects our practices, and the proposed mechanisms are feasible and implementable to be able to support these patients. So remember, we are dealing with the the two co-infections, and of course with more risks of getting more infections. So in a way, looking at the discussion, it now opens up a very big prospect, because we also need to judge what our practice has been and how we can come in support these patients as healthcare providers, so that ultimately these patients do not feel living in an isolated world, because we do not want them to feel so much overwhelmed by the associated stigma, which can eventually make them probably not take the treatments as required, and of course with eventual poor outcome, as we have already discussed before. Now, having gone through activity 2, it's very important for us to also understand. Are you able to see my slides? Can you see my slides?
No, we can't see the slide.
Oh, I have to share again. I'm sorry. I think every time we go for the breakout session, then I lose my slides. Okay, so here they come now. So this is very important for us to really put in mind and be able to incorporate it in our practice, because we mentioned that, for example, the source of stigma for the patients, an individual internalizes the attitude of shame, you know, they are associated with chronic cough, and they have a bit of guilt about their diagnosis. You really don't like yourself, and this puts you at a big trouble, because it's the situation at hand. I mean, this is what it is. So instead of that denial and living in the state of not liking yourself, you have to accept the situation and move on. So the possible solution that we give is that somehow, somewhere, you can sensitize these patients. TB is not a new disease. It has been here since 1900. And in any case, its transmission sometimes is accidental. If you are traveling in a taxi and there is somebody coughing, you can transmit the TB. And also, it is very important for us to give these patients very good hope that the disease is curable. And it also goes unsaid that for such patients, the situation they are in can only be resolved if they seek for health care services. They get to the hospital, they are diagnosed very well, they are treated very well, and they also help others to be able to overcome the same kind of aspect. And to the level of the community is formed of so many people, different hearts, different beliefs, different behaviors. Everything is different. But what we must come to the consensus with each other is that somehow, somewhere, we do not have the reason to reject these people in our society. We do not have the reason to throw all those insulting statements to them. Somebody is coughing all the time. Yeah, but I mean, it has happened, so why can't we support them and welcome them so that they can also go through the treatment phase, and then they heal and they become safer people to live with. So for the community, we'll also have community-focused sensitizations to make sure that they, first of all, appreciate that this person is already a victim, but we don't want him to transmit to the others. And also importantly is that they should also be able to know that sometimes what we seem to look at as a curse, it may not be a curse per se, because it could be that somebody got the illness unintentional, and also the transmission could occur to any other person. So we want them to have some positive attitude towards these individuals and support them through their treatment phases and the eventual recovery. And to the institutions, because we are always involved in so many life maneuvers, we really want to make sure that these people are not incapacitated because of their current state. If, for example, Jabir, who is a shop attendant, is labeled that he's a TB patient, so when you go to his shop, you buy TB instead of buying sugar, it means that he's going to lose survival because his shop is no longer working. If this money he's using is for the bank, and the security put in the bank was his land, they'll come and take everything, and he'll become a refugee of some sort. So we want to appreciate the prevailing circumstance, and we also want to take the necessary precautions, but these people should still belong to our societies. I have personally witnessed that most of the TB patients are a little bit disadvantaged. I remember one person who was a bus conductor, and you know, everybody knows that this one putting on a mask is a bus conductor, and you know he has TB. When he's asking us for money, he can transmit. So we know the risk, we appreciate the risk, but we are not shining them away so that they do not survive. So we also make an effort to sensitize these individuals and make sure that these people are also able to live with us. And most importantly, for people who are opinion leaders or who influence the communities, like the local council leaders, they can also be able to advocate for some ways of supporting these individuals in our societies. We have a TB champions group, and one of them was a former political leader. He has made his entire life to spread the gospel about TB, even other infections, so that people can have hope that you are able to recover and you live your routine. If there are other comorbidities, it's not the end of it all. And in any case, he was one time teaching people on the radio that you can be diagnosed with TB and HIV today, and somebody dies in the accident in the next 1 hour. So having those infections does not have any justification for the end of your life at that particular moment. Of course, this adds on the so many discussions that we have already had from the different groups, and also our routine practices and experience gained over time. And in a way, this marks our end of our discussion that we have had. And I want to take the opportunity to thank the participants, the facilitators, the co-facilitators, our senior facilitators as well, and Winfred and the team for giving us the enabling environment to be able to conduct these module 3 discussions. For me, that's it from my side, but I want to give the chance to my colleague to be able to say some winding up remarks, and then finally we can close this session for today. Thank you very much for your attentive and active participation.
Thank you very much, Ivan. You have already thanked the participants, so I just support what you have said and also the co-facilitators. Last, I would like to urge our participants to remember to do the post-knowledge quiz before the next session. So I would like to say thank you very much for your participation. You have made us be better people by participating today. Thank you very much.
Thank you, Matepo. Winfred, do we have the photo moments today? Everybody saying yes. So with that answer, I ask you to put on your cameras, and then we have our last bit, which is the photo moment. I see very beautiful and handsome faces everywhere. Winfred, Rogers, we are only missing the photo.
Winfred left. Is she still on?
So I just have to mention this from the chat room. Winfred, please go ahead. I'm just trying to mention some few aspects that came up in the chat room. You remember from our previous discussions, we had some challenges with the LMS, and Malik is asking Edwin if the LMS issue has been sorted. I also know there was somebody who had requested for the pre-quiz, but he wanted it to be in French. So have this been resolved? Edwin, are you now able to navigate and have your pre-quiz assessment submitted via the LMS?
For other modules, I'm okay. The only challenge I have is with module 2 only.
It's only module 2.
Yes.
Okay, so it remains with the IT team. They should be able to support. There is a brother from the Francophone. Have you had the requested help of translating the the pre-quiz in the French. Have you received it?
No.
You have not yet, so it is also a pending issue. So like my colleague mentioned, please make sure you are able to complete this quiz. The session 2 normally should do it before we start, and then you prepare for the subsequent week. You do the quiz before we have the discussion today. Okay, I was talking a lot. I don't know whether the photo was taken, but in case it was not taken, I still give the Winfred's team the opportunity to take the photo. Winfred, Rogers, are you able to take the photo?
Set their cameras on.
It's already done?
Their cameras ain't on.
Okay. Okay, it looks like all is done for today. So we request the participants to exit, and the facilitators and co-facilitators and the senior facilitators will remain behind. Thank you very much for today. We meet again next week.
Bye-bye.
Oh, Captain Selina, I think we are left with our routine. So thank you, the facilitators, the co-facilitators, and our senior facilitators, Mariki and the team. Also, thank you, the Secretariat. You have been so helpful for making this delivery a success, because without you, we cannot do much. Incidentally, I only wait on your feedback, and then we can, based on that feedback, to plan. But before I open up for discussion, I think my facilitator should be able to say a word or two, and then we can hear from you. Thank you.
I don't know if you can hear me. Can you hear me?
Yes, we can hear you.
Oh, thank you very much. No, I want to say that thank you very much for the opportunity. And I want to thank you, my co-facilitator, for the good work that you have done. And
thank you very much.
I think you did a wonderful work. You take the co-facilitators as well. They actually supported us a lot. At some stage, my internet did something and I couldn't open especially during the first activity, I couldn't open the slides and I was not able to give clear instructions because of the something on my internet, but we were able to work well with the co-facilitators. So I'm really thankful.
Okay, we have had so many internet challenges, but I'm happy that we are still able to go through this and we can finally come to the end of the session. Now, what can I say? We can only wait to hear from you, our colleagues and the senior colleagues, and then we plan for next week. Any feedback is very much important and helps our continuous improvement and better delivery. Thank you.
Thank you.
Okay.
Can I go in?
Please.
Yeah, go ahead, Selina.
Wait,
Oh,
wait,
thank
wait,
you.
before you go. Just a moment.
Yes. Yes, Mariki.
Congratulations to Ivan and Matabogo. You did very well.
Thank you very much.
Yeah,
You,
very
thank
Thank
you.
you,
nice.
thank
Very
you.
done well.
And thank you everyone, because this success is because you supported us.
Yes. And thank you for the people who came in as co-facilitators, the 4 of you that's still on. I just want to talk about next week because Silabalo just sent me a message, says he's in China. He can't access emails. I think Erdo's name is with him, but I haven't heard anything of him. So I can't trust, I can't, if I don't have communication, I can't work like that. So Shagan has said he's willing to step in. I just want to, Silabalo, can you talk? Because if you can't be on email, I don't know how we're going to plan next week. Okay, can you hear us, Silabalo?
Hello, Mariki.
Yes, hello. Yeah, there you are. You sound like you're next door.
Yeah. That is my worst worry, that I can't basically access my mails. This is why even today I joined very late, because I had to go via Mateboho to send me the link and the likes.
Right.
Yes, that is just
So
the worry.
when are you coming back?
On the 4th of July.
No, then no, sorry, but then you can't access the LMS and all of that stuff. It's going to be difficult.
I'm not sure about the LMS. I will try, but the major problem is the mails. You know, this communication that we have to do with the mails in preparation. I can't
Yes.
basically access the mails. That is the major challenge.
Okay.
Maybe we
Okay, so-
can try WhatsApp.
Yeah, but you have to communicate with the person that you're working with, send them the program and all of that. So,
Yeah, they can do that on WhatsApp. They can communicate on WhatsApp, share the slides.
Take a Zoom.
Okay, but if you can't get connectivity like today, you can't join on time.
I can send him the link once it's available.
We
Yeah,
can
it's
as well have a standby, just in case to cover up.
Yeah.
Yeah, I think Jennifer's proposition is really a good one, because sometimes, so many things take place and we do not want to have any breakdowns in our delivery. So if there is somebody who could be stepping in, that would be much appreciated. Of course, Baro, if you are available and everything can allow, it would also be good that you are able to facilitate this thing.
Okay, so Jennifer, what did you say? I missed that.
I was saying that it's important that we have someone on standby for a just in case.
Yeah.
Yes, for some, if Celebalo is on, well and good. If he goes off, that person can.
Even if it is my network, I can't hear anything, Jennifer. Can the others hear you? If not, you have to repeat for us.
Yeah, what she's saying